welcome. With a perfect day like this, I wondered about whether I should come. But anyway, I'm here. So welcome. And this is quite different than the first one. But just to remember what happened the first time, we talked about the human origin story, but really the origins of the human brain, or at least the evolution of the human brain, over a period of anywhere from 12 million years ago up to now. And but this week we're changing gears, and we're going to talk about a little bit about clinical neurology and neuroscience, which I've witnessed now for over 40 years. And it's been an interesting journey. One of the things that has impressed me when I've reviewed my material for this series is how little we know about the really big questions or the really interesting things like consciousness and what much of the brain actually does. That certainly wasn't my perspective in the beginning, because one of the reasons I went into neurology in the first place was that the brain is marvelously organized, and it's possible with a clinical examination and good history taking to localize many lesions. This is never more true than in assessing patients who are comatose, and where you really have to make a decision about what's going on in a relatively short period of time with the information at hand. So it certainly works that way. We're going to end this morning talking about Neanderthals and humans, but also out-of-body experiences. And what is the nature of out-of-body experience, at least as far as neuroscientists are concerned? Just so you know, there is actually a plan to this. The next week, we're looking at the motor system, its broadest context, and following that, the sensory system and memory, and then the biggie, consciousness, and then the last one of the future of the brain, but also the relationship between science and art and other activities that we pursue. So that's the game plan. Now, anyone who's been a part of any of these series recognizes that there's always at least one or two lead-in slides that has nothing directly to do with the content. But I rather like this one because this is a recent discovery. You probably know that almost every galaxy has a really giant black hole at their center, and the Milky Way is just the same. But now they found another galaxy, and there are actually around 60 black holes, and every one of them is big, in a size that's probably the size of our solar system. So, we keep learning new things, but then that's a product of the brain, isn't it? Finding and discovering things and learning from them, that's it. Now, a few words about neurology and neurosurgery. Traditionally, neurologists have been seen by other specialists as people who are really very good at localizing lesions, but not very good about treating them. And that has certainly been true until about 20 years ago. And there's also a tradition that's fixation on localization. Goes back to the late 1800s with the French school, Charcot and others. And then the Queen Square group in London, England, kind of took over in the first half of the 1900s. But the emphasis, and the person who taught me the most, Richardson, in Toronto, the whole school taught scrupulous history taking and examination. And it worked surprisingly well in a Sherlockian way, and never more so than with lesions in the brainstem and visual systems. It's one of the reasons why somewhere in this series, I want to find some time to actually show you or demonstrate some parts of the neurological examination. And you'll see, and then kind of draw on a kind of a drawing, okay, if you've tested this and it was normal, what are the implications of that functionally and anatomically in the brain and the brain stem or the spinal cord. It's actually a very good tool. It's what I used with students and residents, and I think you'll enjoy it if we can actually do it with this method. But anyway, certainly, you know, for say the first third of my career, and much of neurology and neurosurgery before then, correlations of function and anatomy was really based on postmortem examinations. And often there was quite a gap between the two. And furthermore, naturally occurring lesions disrupt multiple functional systems, even if they're localized. So, but I well remember the CT scanning coming in the mid-1970s. Boy, was that ever transformative, because for the first time, I could actually see, like a slice of bread, slices of the brain in 3 primary planes, and stuff that we speculated about. There's a admit here. We could actually see. So why don't I do that? Okay. So and then MRI was totally transformative. And then PET scanning. You'll see examples of these, as well as now the darling of psychologists, functional MRI scans. Boy, these things have really transformed neuroscience, and certainly neurology. And I have to tell you that neurology has changed. It's become much more interventional. There are a lot of things that are quite treatable these days. So that's a good thing. But at its heart, neurology and neurosurgery, that is the clinical approach to patients, is syndromic, meaning what are the symptoms, what are the findings, where does that point to? Where's the lesion, or where are the lesions likely in the brain or the brain stem or spinal cord, or 2 or more of them. And I'm going to illustrate this with this hemicord or half spinal cord lesion. I'll say one thing, that the localization of the peripheral nervous system is much better, and I'll illustrate that a bit later. I'll tell you, if I had to pick on one system and I could only examine one system and I could learn the most from it, it would be the visual system. Because if you think about it, there's the retina, the optic nerve, all the way to the brain stem that's sitting at the base of the brain. So any lesions along that pathway right up to the brain stem, the upper brain stem, and then it fans out through the temporal lobe and the parietal lobe to the occipital lobe. So it covers 3 lobes. And I've just done the visual fields. But if I now include movement of the eyes, the position of the eyes and the movement of the eyes, well, now I've added a whole other networks. And now if I then include the pupils and the size of the pupils and how they react to light, I've now added another layer. So if I had to choose one system and only one, if that was all I had, I would choose the visual part of the examination. Now, left-sided inattention, I think there was an article that went in the Lake report, but it included my father. And I remember that he had an ischemic stroke, and it affected his right parietal lobe. So that would be just about here. And we were up we owned a schoolhouse up near Beeford at that time, and we were going for a walk, and there was a fence that we had to cross, and I crossed it and kind of forgot about Dad for a few minutes, but then I realized he wasn't with me. And then I looked back, and he had his right leg over the fence, and he was looking very perplexed. He just couldn't figure it out. And I came back and I said, Dad, you know, your left leg is on, you left it on the other side of the fence. You actually have to lift that over. And he had this sensory inattention, lesions that involve the right parietal region. People often lose an awareness of their left side, or that their left side, even if you point to it, belongs to them, and certainly forgets them. And I remember his second wife at the dining room table, he would ignore the food on the left side of the plate, and his wife, who was clued into this, and she would just rotate the plate. So there's an example of a localized lesion in the non-dominant hemisphere in the parietal region. It was an ischemic lesion. With this amazing inattention. On the left side, no weakness. His motor control was fine. So we'll talk a little bit about the three main lobes. One thing I will say at the bottom, I also learned pediatric neurology with one of the world's best people at the time, Stobo Pritchard. And one of the things I learned from Stobo was of observation, because these kiddies would come in and they want to play with stuff, and he'd set up his office with stuff to kind of get the kids' attention. And so while he talked to mom, and it was usually mom, plus or minus dad, but usually mom. And while he talked to mom, he was actually watching the kid and what took the kid's attention and what was the kid interested in? What did the kid actually do with the stuff? And he learned more from just watching the kid than the formal neurological examination. That was a revelation to me. Well, this is the famous case of Phineas Gage. This was, I think, in the 1860s in the US. You'd think no one would survive this, but he was working out a blasting rock with a team to, putting a railway through. And this tamping rod was literally blowing through just under his under the orbit here on his left side, and right up through the into the right frontal lobe. Now, listen, this is the 1860s, and the very fact that he survived, that is quite incredible. But he did, with a major change in personality. I mean, he was a very orderly, kind, empathetic person, and it changed completely. I mean, he became apathetic, irritable, ritualistic, kind of nasty sometimes, became a thief, encounters with the law, various other things. But so that's the famous case of Phineas Gage. So it's now, and here are the usual things that, now there is a reason for this, because I'm going to show you two, maybe three cases later of frontotemporal degeneration, the second most common cause of dementia. And it preferentially affects the frontal and temporal lobes. And the features of the frontal lobe, just what I talked about, this impulsivity, the apathy, lack of interest in others and whatever's going on around them, a lack of warmth, become antisocial, inappropriate joking and crying, lack of tact. And then they also get these reflex changes, they're grasp reflexes. That is, if you stick your fingers out or just stroke the palm of their hand, they just automatically, without any volitional component to it, grab onto your hand. And that's what babies do up to a certain stage. They have a grasp reflex. And so this is returned. And the other thing is that if you just scratch the palm of their hand, the chin kind of moves a little bit, this so-called palm chin reflex. Reflexes that are there developmentally early, then lost, and then they come back with frontal lobe lesions. Now the temporal lobe on the dominant side, so that'd be over here, that's the lobe just above the ear here, and it has a lot to do with speech. But on the inside, or the medial side, close to the brainstem, it has a lot to do with memory. In fact, discrete lesions in this area may make it impossible for people to remember anything past a minute, 30 seconds. And that actually happened to my father-in-law. And that was another ischemic stroke in his case to his dorsal medial nucleus of the thalamus. That's an organization of gray matter right at the base of the brain. and a very discrete lesion. He's now immortalized in a neurological journal, is MRI, because he had this striking, very striking memory loss where, you know, if you were in the room and talking to Bob for a few minutes or exchanged stories and left the room for some reason and came back a minute later, oh, couldn't remember anything that had happened. And that went on for 3 or 4 days, and then it resolved. So so all of these lobes, and if they have an aphasia, that is a problem in formulation of speech, understanding speech and formulation of speech, you can simplify that and say the part of the back of the temporal lobe, Wernicke actually described this, but people who are unable to understand spoken or written language, or both. No problem formulating language, but understanding it is another matter. Whereas, for example, if the lesions in the inferior frontal region, forward, so-called Broca's area, they understand things that they can read, make sense of it, understand verbal language, but they can't sometimes write, but they certainly can't formulate language in some meaningful way. So that's really a brief, and I've already mentioned that inattention business with my father. Now, there are just a few points to mention in all this. Some people, one of the reasons why the history is so incredibly important is that sometimes the neurological examination and imaging studies are entirely normal, but the history isn't. So patients report, for example, tingling or prickling, maybe in a limb or on the trunk, the arm or the leg or the face, but there's no correlate for that pathologically, that is in the imaging study or in the examination. That's really, really common. And it's very helpful, for example, in recognizing multiple sclerosis, because there's often a history of 2 or 3 events beforehand, before the one for which the patient seen you at the time, and you wouldn't have a clue that there have been 1 or 2 relapses before unless you actually pay attention to the history. So the other one is this migraine aura. I'm going to actually show you that. My wife Jan has had complicated migraine, and I don't know how many of you, if the odds are what they are in the public, they're probably at least 10 or 20% of the women anyway have a history of migraine in some form or another. And one of the most common early symptoms are these zigzags in the visual fields out on the periphery, and then they tend to march, kind of creep in toward the central part. And there's actually some people, at least for many years, speculated about what was going to happen. And I'm going to show you what actually happens with functional MRI with that in just a minute. The other thing, sometimes people have findings, but no symptoms, and they wonder why they're there. But this is very common. I mean, a lot of neurology is pattern recognition, and people with Parkinson's disease very early, you could tell long before they have symptoms, because they come in and the leg might be a little stiff on one side. You notice that they don't swing the arm on that side quite as normally, or if they smile, the smile isn't as much on that side, and there's a certain softening of their speech. But these are all things that people kind of ignore or don't pay attention to, but it's pretty clear what's going on. And then there's the other thing. There are plenty of instances of MRI and imaging studies showing irrelevant findings. I think I've told some of you in the past, there isn't a single person after the age of 40 that has a normal CAT scan and MRI scan of their spine. It just doesn't exist. There are abnormalities, maybe not all, but almost all. And I mean, there isn't the same fetish now, but maybe about 10 or 15 years ago, the wealthy among us thought that it would be a good idea to have a total body MRI every year. A good way of scanning things and picking up things that the physician couldn't pick up. But actually, the payoff was almost was very small, but it created a great lot of trouble, because then these little lesions, discogenic lesions, or even the odd little spot in their brain, and things that wouldn't cause any symptoms were going to cause any symptoms, but they worry about them. So there are abnormalities that we pick up in, with various imaging techniques that are just not relevant. Now here's this, if you look at this, this is starting at the bottom left and moving up. This is somebody with that visual, with migraine, visual migraine, with the sparkles kind of happening out in the periphery, and they're kind of moving in. And I don't know whether you can see my pointer at the bottom here, but that's kind of the start here. And if you compare here, there's the clock in minutes going by. So what's this, about 10 minutes? Over about 10 minutes, the activity, the oxygen consumption and local blood flow has increased, and it's moved from the back, the primary receiving area, the occipital area, and moved forward. That's a so-called spreading depression of the brain, and the membranes become partially depolarized and non-functional. And so if it happens on the motor side, somebody will actually develop weakness. But it doesn't last, and it's a migrainous phenomenon. So that's really an interesting one. Now here we come to this hemichord thing. Now it's not often that textbooks screw up. Here's one from Oxford University Press. This is the Brown-Séquard syndrome. Now this is the hemichord thing. What do I mean by that? Meaning that if you might kind of slice the spinal cord, not across it, but only half of it on one side. And that creates a kind of a peculiar findings that you know exactly where the lesion is from the clinical examination, because on the same side as the cut, it interrupts the sensory information from the skin about light touch and two-point discrimination. But it also interrupts pain and thermal sensation from the other side, which has crossed over to that side. So it interrupts both of them. So loss of pain and temperature on one side, and loss of touch and two-point discrimination on the other side, and the paralysis will be on the side of the loss. I mean, that was described by Brown-Séquard and two people back in, well, I think the early 1900s. But anyway, it's one of those things, because when people describe this, and they probably won't just describe the loss of thermal sense or pain on one side, but they'll certainly be aware of the prickling and the numbness on the side of the section. And depending on, like on that picture there, the upper limit of that is just above the belly button, or the umbilicus, and so that would probably be around thoracic 10 or 8, and so the lesion's probably around D8 or maybe D6 or 8, something like that, just a little higher than the sensory level. So it just shows you that the examination itself is a very good predictor. Now I put this one in because one of my good colleagues and continuing friends is Alan Roper, who's a professor of neurology at Harvard, and very, very good teacher. And but this also, now this happens to be the peripheral nervous system, but it's all part of the nervous system here. And if you look at the bottom here, that red thing there is a disc protrusion. And it's between the L4, lumbar 4 and 5 vertebrae here, but it's catching the L5 root going by. And I can tell you with about 95% chance of being correct. And if this patient has any symptoms, those symptoms will be that they might certainly back pain and pain in their buttock, but that's not terribly helpful, although it's distressing. But if they tell you that, gee, I've got some prickling and numbness over my shin, and it extends over the top of my foot, and you know what, doc, it involves the big toe. I know exactly which root that is. That's the L5 root. And if they told me it was on the side of the foot, the lateral side of the foot, and the bottom of the foot, I would know it's the next root down, the first sacral root, with a very high probability that I'm right. I might be unsure about which level it is in the lumbosacral cord, but the predictability of the root, the symptomatic root, is actually quite high. So, and here's an example of one such disc. This thing doesn't show up all that well, but I don't know whether you can see the cursor here. But there's the disc here between L4 and that's L5, S1, the first sacral vertebra here. But there's the disc, and here's the affected level, because here's the disc right here. This is the back. This is the bony thing that you could feel at the back. Yourself a kind of bumpity bump the spine right here. But look right here. That's where the nerve root exits on both sides. There isn't any room. There's no room for a root there. By the way, this white stuff here is all cerebral spinal fluid. And those little dark dots in there are the nerve roots. Okay. Now here's another level, one level down. So this is between 5 and S1. There is no disc at that level, or it's very small here. And they're kind of wide open on both sides. By the way, I can tell that this person doesn't exercise very much, because if I look at these paraspinal muscles down here, you can see all the fat that's replacing a lot of the muscle in here. There's the muscle, that kind of darker gray stuff, and it's all infiltrated with fat. And there's also a lot of intra-abdominal fat here. This is the bad kind of fat, because it's different than the stuff that's under our skin and that kind of thing. This one actually makes hormones, which aren't great for health. So talk about that another day. Well, here we are, CT scanning. I'm not going to go into the methodology of this too much, but I did say earlier this was quite transformative. And here's a good example, because if I had seen this person in 1973, 74, no CAT scan available, this person might not have had any symptoms at all. This person has metastatic cancer to the brain. I might have known about the primary, but not the stuff that was going on in the brain. But here's the CT scan, and you can see this large metastatic lesion in here. That's that kind of size and location that might not be associated with any symptoms. It's displacing the brain a little bit here, but not much. And they're actually, it's hard to see because it's so granular, the image here, but there are actually many small little lesions. And if you see one like that, there's a very, very good chance, don't be tempted to go in and take a single one out like that, because it's not single, there'll be multiple such examples. So that's something to think about. Now, I'm going to look at how imaging has changed our stroke management. I said earlier that neurologists and neurosurgeons, for that matter, had nothing to offer for people with vascular disease except for aneurysms. And when I was in London, I was very lucky to work with some of the very best people, one of them certainly in the world at the time, with an expertise in clipping these ruptured aneurysms. But aside from ruptured aneurysms, there was nothing anyone could do. And here's the problem. Here, this somebody, look right here. Just now, this, by the way, right side is on the left of the picture. Okay, and so this is the right side. So this patient would have an opposite paralysis or partial paralysis on the other side, so on the left side. And look at this high intensity lesion. That's a blood clot. in one of the main blood vessels supplying in this case, the right hemisphere. And so it's that clot is actually quite extensive. And now there are some subtle changes in the CAT scan at 50 minutes. There is this window of 3 to 6 hours, 3 to 6 hours when you really need to get a clot like that out. In this case, they attempted to dissolve the clot. It didn't work. And you can see that the 25-hour mark, this large, the brain is dead. Where it's dark here, that's dead. And look, when you go a little higher in the brain, this is the brain stem in here, but looking higher, this is an enormous lesion here. So it didn't work in that case, but here's an example where it does, because this is an angiogram taken from front head on. And here's the same vessel right here. In fact, you can't see it. There's the stump. So the clot is in there, that no blood getting through this middle cerebral artery, which supplies maybe 50% of the cerebral hemisphere. And they threaded a catheter. You probably can't see, well, there's a big white arrow pointing to it, but there's the tip of the catheter and where they injected the thrombolytic agent. And look at what happened. Not long later, the blood supply has been restored. So it's really quite dramatic. And but it does bring up a concept of which I'm just going to introduce now, and that is that at least with ischemic stroke, that is, lesions are associated with a block in the arterial circulation. What happens is that there are really 3 areas of brain: the dead part of the brain, the part of the brain that's at risk, at serious risk, and then the normal part of the brain. There's nothing you can do about the area of the brain that's dead. It's dead. But so what you're rescuing with whatever you do is the brain at risk. And here they've kind of drawn in here with this cartoon like here, but the area of the dead brain is that red stuff. The brain at risk is a much larger. So if this part of the brain actually died, there would be a severe disability here. And in this particular case, they were able to get the clot out, and that green stuff, blood flow was restored to it. So that's a good outcome, and that's where we're going. So that's a quick window on, I can say that they've become far more interventional these days, and thank goodness, for ischemic stroke, not so successful if you have a bleed, but anyway. Now, here's another issue. Multiple sclerosis is really common in Canada, and I think it's around 40 or 50 cases per 100,000. And I looked after, or the 2 of us looked after around 1,500 patients with multiple sclerosis. One of the things that always struck me about this disease, which causes a loss of the insulating sheath around nerve fibers, and the consequences of that is that transmission, electrical transmission along these nerve fibers is slowed. And if it's slowed too much, it actually blocks. So the transmission is completely stopped. But one of the amazing things is how many lesions there can be. I mean, look at them all. These white areas in the brain, and there are some of them in the cortex, or just below the cortex. There are a lot of lesions here. I've seen that and a lot more with no symptoms and no abnormal findings and no cognitive impairment. That's actually an extraordinary thing. And because it happens, you know, I think when the CAT scan first came in London, I think in 1974, if I remember right, the first patient I sent down for a CAT scan was one I was a little worried about. He'd had a history of an odd seizure, well controlled with medication. That was it. His examination was normal. The CAT scan showed an enormous brain tumor occupying 3 lobes on the right side, with no findings to go along with it. But it was turned out to be a very low-grade tumor, and in the nervous system, if things happen slowly over years, it's amazing how little dysfunction actually occurs. I mean, if anything that catastrophic or that size happened over a matter of weeks or months, there would be a lot of symptoms and findings. But if it happened slowly, and in his case it did, so really we kept our hands off because we thought we could only make this worse. And this person has actually did do quite well for, I think, the next 8 or 10 years. And then I kind of lost track of him. I think he moved west, but so I don't know. I've always been grateful for keeping our hands off. Now here's another, this are horizontal slices in another patient with MS, and it shows just how extensive these lesions are. But there's more to it than that. This white stuff here is cerebral spinal fluid. There shouldn't be anywhere near that amount of spinal fluid showing up. So it's really telling you that the brain has shrunk a lot. There's been a lot of damage in the brain, and the brain has kind of shrunk, creating this space, which is filled now with fluid. And the fluid is this white stuff. So there's been a lot more change here. This probably went on for years and years. Now, here's something that might be hard. I pointed out with multiple sclerosis, it's very common to have a lot of lesions with no symptoms and no findings. But that is not the case in the spinal cord. The spinal cord is about as big as my finger in diameter, and it's jam-packed with systems that are very intolerant of anything going wrong. So a little lesion up in the brain, the same size or smaller in the spinal cord, is going to be symptomatic and have findings, and sometimes take people right off their feet. And you can see there's the spinal cord, that gray thing. The white stuff is spinal fluid. You can see the cervical spine, first, second, third, fourth, so vertebra on the way down on the disc. So you'll know also that this is a young person, because there's very little in the way of discogenic or bony disease at all. So this would probably be a young woman, but that light white stuff along in there, those are lesions in the spinal cord. And that's often associated with difficulties walking, stiffness in the legs, weakness in the legs, and sometimes trouble with the bladder. So the spinal cord is very sensitive to changes. Now, we're going to change gears a little bit, because today is a bit of a show and tell. We're trying to cover some ground here to set the stage for the next 2 weeks. I included this particular problem because it illustrates something about the natural history of diseases and our ability to recognize it. Now, Alzheimer's disease, the familial form, meaning the inherited form, is probably only 5 or 10% of the total. And the dominantly inherited one, meaning if you've got one copy of the gene, you will get Alzheimer's disease, and you will get it probably 1 or 2, maybe 3 decades earlier than the sporadic form. So the interesting thing here is this figure speaks volumes, because just this is time. Now, where's my little cursor down here? Time 0 is when the diagnosis is made. They've recognized that this person has, they made a diagnosis of dementia, possibly Alzheimer's disease. But because it's autosomal dominantly transmitted here, this person's been known about and has been tracked for 2 or 3 or more decades before. So you get to see, well, okay, when was the leading edge of this disease? When did this disease actually begin? Not when the diagnosis was made. When did it actually begin? And I'll just, one of the characteristics of this disease is an abnormal form of amyloid protein is deposited outside nerve cells. And that's that top part here. And look at it, it goes back, 10, say 2 decades. The beginning of the accumulation of beta amyloid. The same is true for the other protein that's often deposited in this disease, probably goes back 1.5 decades. The hippocampal volume, why are we thinking about that? Because the hippocampus plays a huge role in memory, in the formation of memory, the retention of memory, the ability to recall memories of all sorts. And there's the volume beginning to shrink. Now, if something's shrinking on a macro scale that you would pick it up with an MRI or a CAT scan, it's been there for 5 or 10 years before that. So the point of all of this is that from a biological perspective, this disease began at least 1.5 or 2 decades before the diagnosis was made clinically. And it probably began before that, a decade before that. Well, we know it began before that because this person has the mutant gene. So that's been in play for a long time. Now, why am I driving this point home? Because if you're going to do anything effective about this, the time to do it is back here. Way back here, not here. It's almost too late at this point. By this time, people have lost 30 or 50% of their nerve cells. So, and they're not retrievable. So, so that's the teaching point here. It's also, if you take this profile and you say, gee, is that what happens in Lou Gehrig's disease? Yes. Is that what happens in Parkinson's disease? Yes. It happens with other neurodegenerative diseases where they've been brewing for a decade, maybe 2 decades, 3 decades before they surface clinically, before the patient becomes aware that there's anything wrong or the family becomes aware of anything wrong. So that's the point. And it's also the bugbear for clinical trials, isn't it? Because if you're going to design an agent to help out, and every single trial has failed in Alzheimer's disease, doom and gloom, kind of as of a year ago. But if you look at the trials, they all, the trials were carried out on people with symptomatic Alzheimer's disease. Well, looking at the graph here, that's too late. Now here is a comparative PET scan here, and this reflects the amount of the deposition of amyloid. A, B, and C are kind of carriers. So beginning 20 years before on A looks normal. And then the carriers are the one carrying the mutant gene. Then we start to see something beginning to pop up in B. That's 10 years before the diagnosis. And at the time of diagnosis, my heavens, look at that. A whole lot of deposition of this protein, whereas the non-carriers, no difference right across the 20 years. So quite a change. Now, there's been a lot of talk about concussion injuries and in the the major professional contact sports, the NFL and CFL and the football and hockey. Hockey's been less forthcoming about this, but both of them have been dragging them things. And of course, a lot of these injuries took place in university or in high school. So there may have been many more injuries, or may have been a lot of injuries in their professional career, but they're probably double that if you include their high school time. So And this is just a slice to show what if you look at the aggregate. You take these veterans of the NFL here and compare them to controls and look at their brains. Where are the injuries? Well, they're where the red is. And no surprise, they're at the front pole of the temporal lobe on both sides, because that's a sharp edge, sharp bony edge. And when people are concussed, the brain kind of jiggles around, and then it's torn, and there are little hemorrhages where it abuts these sharp creases of the bone at the base of the skull. So that accounts for these temporal lobe lesions here. And I'm not sure what accounts for these lesions up here, but lesion in this kind of localization up here sometimes is associated with problems with the so-called executive function planning, long-term planning. So something to kind of think about with that, and heaven knows why this left parietal thing came through. I have no idea. Now, we're going to look at these frontotemporal degeneration ones, because we're all used to talking about Alzheimer's disease, and we forget about frontotemporal degeneration. I told you it's the second most common cause, and especially a decade or two younger. So the two cases I'm going to show you are people in their 30s and 40s, early 30s and early 40s, both men, but not all men. They're not all males for this, but I'm just going to show you this MRI, and stay with me as I kind of show you that this is this fellow. The top row are the slices done when the fellow came. This is kind of 3 years before this patient was formally assessed at the Massachusetts General Hospital. Okay, and what you see, I mean, you don't know what's normal here, but these ventricles, these fluid-filled ventricles, are huge already. This is 3 years before they actually saw them, and you can see it on the side here. Now, you begin to see the frontotemporal degeneration, because here's the frontal, this cingulate gyrus along here. Lesions in this area are highly correlated with apathy. And but look at this. By the time the current admission, look at the size of the ventricles. That means the brain has really shrunk, really atrophied a lot. And look at those changes in the so-called cingulate gyrus here. This is the medial side of the frontal lobe in here. The emotional part of the frontal lobe is right down here, just above the orbit here, and the cingulate lesion. So this is the emotional part of the brain here is heavily affected in frontotemporal degeneration, just as it was with Phineas Gage. So a very striking change. Now, here's one that's 31. And I'm not going to go through the stuff on the left and the right, but here are the same kind of lesions. There's that same cingulate, the medial frontal lobe, the base of the frontal lobe here. So that probably accounts for the behavioral changes and the shrinkage of the brain in the frontal lobe and temporal lobe. Sometimes one variant of this really strikes the speech area, and these people present with a progressive speech problem, but their intellect and behavior remains normal for a long time. I had a lady in Thunder Bay like that, and I tracked her for, I think, almost 10 years. So what are the criteria for this? Well, it reads like the list for Phineas Gage. Disinhibition, meaning doing things that better judgment would keep in check. Early apathy, this loss of empathy and sympathy, ritualistic behavior, but relative sparing of memory, unlike Alzheimer's disease. So that person fit this. Now, one of the things this is one to kind of muse about, because this has sometimes been used in fellowship examinations, but it's also been used with PhD dissertations to ask somebody, all right, tell us what happens with walking. Or I have in my mind an outfielder, and somebody's hit a long ball and it's over their head. And so describe what's happening in the nervous system. Well, we don't know what's happening in the nervous system, but you can make some guesses. The extraordinary thing, though, the brain is enormously complex. It really is. I mean, there may be, I don't know whether it's 80 or 100 billion or 120, I have no idea. But the point is, some of the nerve cells I'm going to talk about next week, they have connections with 10 or 20,000 other nerve cells. This is a very, very busy telephone exchange. And neurons are, each neuron is often talking to many people and receiving from many people. So it's enormously complex. So I just put this together and I thought, so for example, walking. Think about this next time you go walking and think about what's actually going on in your brain. And all the related, so I'll just read this out. For example, walking involves the legs, the trunk, and the arms. It actually involves more than that, but let's just stick with that. And all the related nerve cells and connections within and between the spinal cord, the brainstem, the primary motor and sensory, supplementary motor, frontal, parietal, temporal, and visual neocortex. So the whole brain is lighting up here. You ever seen an fMRI of somebody playing the piano? The brain lights up all over the place on both sides. So there's a lot happening. And if we consider the mood of this person, like today, it's a lovely day out here. You might be feeling quite cheerful, or maybe a little out of sorts with the weather. You don't feel as good as the weather looks, and maybe other things are preying on your mind. But what does that involve? Well, a whole bunch of other areas, like the cingulate gyrus that I showed you were so shrunken, and frontal temporal degeneration, and the related areas at the inferior, the orbital surface of the frontal lobes, and the temporal lobe, and the insulate between the big divide between the frontal lobe and the temporal lobes. And then, of course, there are thousands, well, millions probably, of peripheral receptors and the related systems for vision, sound, balance, and all the rest. So it sounds really simple, thinking about walking, and then you think about what's actually engaged with an activity like that. A lot of the brain is involved. If you did functional MRI studies, though you can't do that on somebody walking unless they're somehow stationary and just walking on a treadmill. But I can tell you right now, as much as we're enamored with functional MRI, it wouldn't show more than 10 or 15% of this. So there's a lot of stuff happening subliminally. And here's something, that's one of the toys that's come along in neuroscience just in the last 10 years. All of the emphasis has been on nerve cells, but not much on the wiring between the nerve cells. And so with fiddling with how you do MRI scans, you can choose to enhance these connections. And that's what you see. Never mind, ignore the stuff on C there, but A and B, you see some of these pathways. It looks really complex. This doesn't begin to touch how complex it is. This is really raw stuff here. These are kind of the major pathways that really stand out, and even they look pretty crude. And I say this because Europe and the United States both launched mega buck programs, 100 billion euros or the equivalent in Europe, and the same in the United States, independently of one another. They started about 5 years ago, and almost all the emphasis was on imaging. And people were just transfixed with images like this, which in my view has been kind of a dead end. It tells us something, but not a lot. I will say some people with dyslexia, some of the dyslexic syndromes, of speech, people unable to read, some of those connections, I don't know whether I can emphasize it, this little band connecting here, this would be kind of the motor area of speech over here. This would be the receiving end, or at least the sensory part of speech here. So the stuff that's coordinating the two, and this would involve reading in here, speech recognition. So yeah, there's some value in it, but not a lot. Now let's deal with this out-of-body experience. This is, single case reports are sometimes very revealing. This literature on out-of-body experience, what do I mean? That somebody, I guess, a common situation would happen in a cardiac cath lab. And something happens, somebody develops an arrhythmia or the heart stops. And the brain is momentarily ischemic. And not many, but some of those people, when they come to, tell a story something like this, that I had this sensation that I was out of my body and I was somehow back in the room, and I could oversee, I could see the doctors, I could see the gurney, but I was detached from this odd experience. And in the early days, I mean, these kinds of experiences were sometimes, they had reported for at least a century before that, and sometimes they were considered spiritual experiences, which they might well be. I don't want to get into that, but what's interesting here is this case is somebody who had tinnitus, buzzing in the ears, and most of us of a certain age have it, but in a very small fraction of people, it's really intense and it's really disruptive for life, and they really can't do anything else. And this particular person, that was the case. And so one of the ways of treating it quite effectively is to identify the area of the brain that's actually associated with the generation of this buzzing, or at least processing it, and stimulate the area with a kind of a brain pacemaker, if you like. And the area that's been identified is at the back end of the temporal lobe, just where, right near the parietal lobe. So it would be about here, and about that size, not much larger than that. And so that's what they did. They used functional MRI to actually identify the area that was active. And then what they did, with permission, all that kind of thing, they put a little electrode, stimulating electrode in, right over that area that seemed to suppress the tinnitus. And then they did an interesting thing. Of course, tried out the stimulation. And with certain parameters of stimulation, little bursts of high frequency, like maybe 5 in a train at 500 hertz, and a whole bunch of these, this patient reported this out-of-body experience. And if you change the parameters of the stimulation, didn't. And there were actually several patients involved in this, and I think there's a total of 5. So it's interesting that they could create with localized stimulation of the non-dominant hemisphere, the right hemisphere of most people, in the back part of the temporal lobe, right where it's adjacent to the parietal lobe, create this kind of bizarre sensation. And and there's the, you probably can't see the electrode, I can barely see it myself, but anyway, this whole area seemed to be involved with the tinnitus. And the electrodes, I think the green area here was the area that was most sensitive to the stimulation and suppressing the tinnitus, and that's where they put the electrode. And here's what they got again with functional MRI. So here are the areas of the brain that lit up when this patient had this experience, but not when the patient didn't have the experience. Okay, you could stimulate it with different parameters, and the patient wouldn't report this out-of-body experience, and the functional MRI didn't show any of these changes. But here it is. All of these things are on the right side of the brain. If it's orange here, it's on the right side. And so this large area, kind of posterior temporal parietal region, no surprise about that. But then there's another area, this precuneus area, which is an odd area, the medial side of the non-dominant hemisphere, that seems to play a big role in awareness. And another area down here at the bottom in the thalamus here. So several areas kind of lit up here. So so that's the out-of-body experience. I thought you might enjoy that. No, I don't know how we are. We're past, aren't we? Okay, well, listen, I was going to do this last week because there's too much on the plate, but I do want to get to this business about the mini brain, the ability to create kind of a several millimeter model of the human brain, which is relatively accurate in many ways, and what we're spending our time on. So it's going to be number one next week. And so I hope that's been interesting for you. It's been kind of fun putting it together. So I hope you found it the same way. But anyway, hope to see you next week, same time. So we're next week talking about the motor system, writ broad, and then the sensory system, and then it all plugs into the next one to follow on consciousness and awareness, and then the last one on science and art and the brain in both of them, and what's the future of the brain. So that's the plan. So thank you very, very much.